injuries. I think the whole thing for the week is adolescent. And so I don't know if any else would tie in kind of like they did with the fractures, but let me know if there's anything even kind of off tangent that comes up too. Feel free to chime in. The first few parts will just kind of be going over some of the basics that we want to talk about, kind of understanding the epidemiology, these types of injuries, some on the equipment, kind of when these injuries are happening, will, I think, help you sometimes understand at least in clinical practice, how to educate people on these. And then things like sports physicals, where we're trying to explain these possibilities, or again, kind of in other visits where maybe other things are coming up, but just some small things. And then obviously some prevention component. So unfortunately, these are pretty common. Sports are the most common cause of pediatric injuries. A lot of these are, they think up to a third are sports related. And again, this includes things like cycling that isn't necessarily an official team sport, but just more being active and participating in these things. This is one study just showing how often it's happening. Musculoskeletal injuries were the second most common reason for visits to the office and ED. So again, even though you guys might not see this a whole lot in our area, because we do have so many providers around that take care of these in private practice, these will become the second leading statistically thing that you'll see. And then again, sometimes randomly in the ED, obviously we're dealing with them a little bit different ways of making sure. And I think a lot of times I always want to convey that, you know, just because it's not broken doesn't mean there's not a problem. So we'll kind of go over some of these details of the components of the injury. So which kids are getting it. So you see this is the graph of showing kind of the basically when it's happening age-wise. Obviously, males tend to have a higher rate of these increase in severity with age. Obviously, the more force can be generated. And then again, a lot of factors go into like the common reason this is, but 1 in 5 kids will have some type of sports injury during their time. In preteens, it tends to be upper extremity, and then as they get older, it goes down to the lower extremity. The most common thing that we see is the sprains and strains. Obviously, fractures is up there though, and then so clavicle is a very common one, where they're falling on an outstretched arm. Obviously, just abrasions, contusions, and those, obviously, the reason that number is low is a lot of those don't come and see us, but that is the diagnosis most of the time. And then lacerations obviously can be included in this, and sometimes it will be multiple injuries, right? You'll have the laceration and on top of it, injured some other soft tissue. But overuse injuries obviously is half of all these injuries too, and so understanding where these injuries are coming about. So severe injuries, about 1 in 4. Playground injuries, it's very high up there, where kids are falling off. But again, these are where thinking through that, you know, these aren't always just bumps and bruises. Unfortunately, catastrophic injuries is high up there too, where you got the injury where you get the death in sports from a cardiovascular, and the commotio cordis, where you're getting hit right in the chest, can cause it. And then cheerleading is very catastrophic too, because some of the heights and things they attempt to do. Epidemiology wise, again, where and when these things are happening, is thinking through the different things with sports, practice versus games, often at school. Again, there is statistically shows holidays, more stressful times in their life, can cause it. Not wearing the protective gear, as we'll talk about, that's often they like to ask that on a test question about proper appropriate protective gear, because again, as pediatricians, that should be our job, is preventing some of these injuries, where wearing the proper helmet, wearing it right, can cause a great reduction in these injury types. Again, this is some more statistics on which sports are causing it. And again, you see it's a wide range where bicycle is up there. And then obviously things like football, but a little bit of everything. This is comparing adults to pediatrics. So this is just, again, where kind of just showing that how things, again, are different in certain situations. The highest rates are obviously football for boys, cross country, and girls. Again, overuse. You get into the female triad of poor intake, abnormal periods, bone problems, that sort of thing. The rates where basketball combined can be very high up there. And again, where baseball can be fatal because of the injury with the ball flying off. But again, a wide range of things. And depending on where you live in the country, obviously this changes, where if hockey is much more prominent up in the north. These are some of the reasons that they try to say why it happened. So motor skill, where they weren't doing something as appropriate as they should. Ball skills, where the injury was from the ball. Fouls, where someone else caused the injury. Simple motor errors, and then cognitive errors. So again, not being smart about what we're doing. So again, it's a wide range of why these injuries are happening. Understanding, again, the big picture with overuse injuries. So making sure we get proper rest. Again, educating these on the sports physicals, that beginning early in age and specializing can be very problematic. So this is where, again, thinking through, as we'll talk about at the end, some of the best players in sports didn't just play one sport all the time. They did multiple sports, and this is highly recommended by the AAP, and preventing year-round participation. So trying to kind of think of how, this can happen. And so that an example was just one kid that was doing tennis and doing more than 20 hours a week of just tennis, because he was in different instructional things and with his teams and then on his own. So that can really add up and cause some problems. This is a model of just kind of showing how this works. And again, all the intrinsic factors that play a role in predispositioning the athlete. And then once there's an injury, kind of how people heal. And then obviously poor healing can cause detrimental outcomes. And so making sure we are taking care of this on all parts is very important. And then specifically with how the kids are coming, as we talked about some with the fractures, that their ligaments and areas are different in kids. And so that's where, again, the ligaments are sometimes functionally stronger than the bones. So we're less likely to think about that. But as they become adolescents, that does switch over. And we talked about some fracture differences. I think someone brought up green stick fracture last time. Again, that's the bowing. And you got the torus fracture. So you got the growth plate injuries like we talked about. And again, growth spurts can play a role on this, putting tension on areas that we don't normally have that tension. And so the adolescent, where they're growing, puts a lot of stress. And then we got kids in all different ages playing against each other. So that can kind of play a role too. And then understanding that kids less than 10 have the overall propensity, just because they're feeble, less slow reflex, all those things. I was just basically going to go through some cases again, trying to kind of tie all that in together, but then again, very specific things like you see. So this one is a 13-year-old that comes in for heel pain, that plays soccer, insidious onset, plays on multiple teams, practices a lot. She's tender over Achilles tendon. She has tight heel cords. So what sort of things are you guys thinking on this case?
Tendinitis.
I couldn't hear it. Someone said something.
Tendinitis.
Tendinitis. Okay, good. So, and then that's where, again, tendinitis should definitely pop up in your mind. And then trying to differentiate that, her being a little bit younger on the edge puts tendinitis down below something else. When tendinitis obviously would, in our age, would be number one on the list. But then thinking through, again, the different anatomy wise. So you got Achilles tendinitis, and then what else would you be thinking of?
I mean, it could be a stress fracture.
Okay, good. And where would the stress fracture be?
Well, On the calcaneal.
Calcaneus. Yep, good. So the calcaneal stress fracture. And so that's on one end. And then we got tendonitis. And then there's one thing kind of in between that, which is kind of merging those two ideas. And it's, again, ped specific.
I forget what it's actually called, but it's basically like inflammation of the insertion site
Good.
of the tendon. And the,
Yeah. So at the tendon site. So there's insertion of the tendon at the tendon site. So there's like entitis, which is kind of more in the room. And then we move over to the growth plate or apophysitis. And then so there's a calcaneal apophysitis, but there's a specific name for calcaneal apophysitis that you might need to know for the test, because they might just put that instead of where I think they should just put calcaneal apophysitis. But then there's a person that invented it, I guess. Does anyone remember what that's called? And that's where it's hard, because again, on the test, maybe you can narrow it down. And this is where in real life you would say, okay, well, I can Google calcaneal apophysitis, the more sophisticated term, and get the other one to tell the patient. So this is Sievers disease. Yeah. So Sievers is the other name. So very common. And they say x-rays seldom help because you sometimes get weird views. So this view you see here is actually like a bifid calcaneal apophysis. So it kind of looks like there's a fracture there. So sometimes you start overrating it. This is where, again, without direct trauma, just kind of assume it's this and treat it appropriately. Does anyone remember how we treat this? Rice, good. So that's always going to be a good thing to say in sports injuries. And then I think that's where the key is rice is something that most people should know about. Not everyone does it, so us reinforcing it, I think, is important. And then we always have to take it one more layer. So every injury almost has one other thing that you would want to do, and this one is very important to know. The key is what's causing it. So how do we fix it? Because just rice will fix everything, but how do we specifically help this problem?
Is it like heel cushions or lifts or something?
Mm-hmm. So yeah, if you can get the cushions to help lift it, you just take away that tension. And so heel cord stretching to take away that tension, and then temporarily the heel cups absorbing that shock, multiple layers of that. And again, that's where you'll fix the problem temporarily, and then physical therapy or teaching about the stretching, and then obviously some modification can help a lot. So what's the similar problems in the knee? So everyone usually knows one.
Osgood Schlatters.
Osgood Schlatters. Yep. So that's the other apophysitis. And does anyone remember the other one? So you go from. So Osgood Schlatters is right where, again, most people learn that one. I don't know why they're not always taught in succinct, but again, Osgood Schlatters, and we'll talk about the other one in just a second. Remember, this can be bilateral and you know, a fourth of the cases. And again, it's a traction apophysitis. So we got where that patella tendon is attaching at the tibial tubercle. And so they'll come in kind of classically with a bump there sometimes, but just tenderness right there. And again, Achilles or patella tendonitis can present very similar, but this is where, again, knowing the age is helpful. Fortunately, the treatment is very similar. Understanding that sometimes getting an x-ray in this situation can be helpful, but don't misinterpret these as like avulsion fractures, where I often see that happening. And so it can look weird with how these develop over time. So you can have different little ossicles and stuff. And then again, treatment would be a strap like this to take some of the tension away. And again, physical therapy to stretch, along with, again, rice, like we were saying. So does anyone remember where, if we said now it's at the distal pole of the patella, this is the other end. So at the other end of the patella, does anyone remember the name of this one?
Patella femoral syndrome.
So patella femoral is kind of its own entity, which is very important in thinking in these situations. But the patella femoral is more about the alignment of the patella in that groove. And this is, again, a traction apophysitis at the distal pole. So don't don't again forget that avulsion tibial tubercle could be possibility. So that's where that X-ray looks very different than the just traction apophysitis, and that person wouldn't be able to extend their knee. But this other one is called Singding-Larsen-Johansson syndrome. Again, a fancy name because of two guys. One guy with a hyphenated name came up with it. But again, it's a very similar place. But this would be where they're not tender over their tibial tubercle, but they're tender over their inferior pole. So sometimes on the question on the test, they kind of throw you off because they'll just put tenderness over the inferior pole. And this is the one. And so again, treated very similarly. But an entity that's a little bit different. So if you go in thinking one thing, it can throw you off because they're not tender at the right spot. Does that make sense, everyone? So the second case is a 15-year-old girl who was playing basketball last night. She inverted her ankle. She's able to walk with some crutches. The ED did some x-rays. They said were negative, put them in a splint, and then had them follow up with the pediatrician. So what are you guys thinking in this situation?
Ankle sprain.
Okay. And then that's where I'm gonna go to the next level. So what kind of ankle sprain, or what kinds are there? Because that's where, again, a very important differentiation would be trying to figure out, does she have, again, just a typical low grade ankle sprain or what?
You can have a high ankle sprain.
Good. Does anyone remember, like, or what is that? What is a high ankle sprain, or what's the other name for it? Or what's involved?
It's the what's it called? The stuff between the tibia and the fibula.
Yeah, the syndesmosis.
Yes.
Yes. So the area up high where the tibia and fibula are together. Good. What else would you think of? What are some of the other possibilities?
And my DO brain says fibular head problem.
Good. Yeah, so that fibular head is that associated massive wall fracture where it generates the force up there. So if you just got in, this is where, again, when we talk about examining patients, you always want to examine someone with an ankle sprain, their knee, because they could have sprained their ankle, but the force generated all the way up. Basically the force is somewhere else, so then the x-rays wouldn't necessarily indicate that there is a fracture. So just like you're saying, thinking about what else could be going on, examine that, and then x-ray it if needed.
And then the base of the fifth metatarsal as well.
Yep. So that avulsion type fracture down there would be possible. Again, the other way, don't miss the foot. And so that's where, again, your physical exam would be very important in this patient. And then what if, again, I said they had a fracture, but you're missing it? Where again, is that in your differential? What type of fracture am I talking about?
The typed ones that we talked about the other day that I'm blanking on their name right now.
Yep.
Salter-Harris.
Salter-Harris, good. So Salter-Harris type 1 would be, again, where you could say this person is tender over her distal fibula, and you could say she has a Salter-Harris type 1 fracture without the x-rays being positive. So again, these are some differentials you got to think about. I think one of the biggest one is the one at the bottom, the OCD lesion. So I think we might have mentioned that briefly, the Osteochondritis Dessicans. That's where you knock off a little piece. Very important to think about in these, and again, why getting x-rays sometimes, and you have that stress area up there at the syndesmotic area. And that can be, again, helpful, again, just to review the Salter-Harris fractures, because I figured people would forget, understanding that those are an important differential that you have. And then ankle sprains, obviously, like we talked about, often on the test too, some reason they want you to know that the anterior talofibular ligament is the most common one. And then you got the calcaneal fibular at the bottom. Again, these areas are expected to be tender, but not necessarily tender right over the bones or the posterior part of the bones where they're not attaching. So sometimes it gets interesting, making sure we order the x-rays right, as we talked about before. And then treatment wise, again, Rice, going over this very specifically, I think sometimes helpful. And again, understanding if we talk about just a very minor sprain that you don't feel any laxity, you feel like they're doing well, this is where understanding that I need to protect it to help it with bracing, but then progression where physical therapy, walking on it has actually been more beneficial. So I think obviously this is where short term the ER will give them crutches, right? But sometimes your job is to tell them, I don't see a fracture, I don't feel any laxity, you're moving it all well. So I think you need to start rehabbing it because statistically you will get worse if you don't do anything, if you just stay off of it for weeks at a time. And I think that's the hardest part sometimes to make that call because sometimes we don't want to push people too hard. So the next case is a 17-year-old tennis player. Like we were saying, practices a lot. Now he started having right-sided lumbar pain for weeks, mostly when he serves. He's not feeling any radiation or neurological symptoms. It's affected him. His primary care doctor got x-rays, MRIs, but say he's seeing you about something else, and then he mentions that. What are you guys thinking about as a possibility?
Costochondritis.
So costochondritis would be costochondritis would be more anterior, but the similar idea of like where it's attaching in the back would be possible, where the ribs are attaching to the back would certainly be possible.
I'm thinking more muscular.
Okay, so some type of muscle injury, so muscle spasms, you know, a muscle tear, and then some lingering effects of that would be possible. What else? Trying to think, again, big picture.
I guess if he's hyperextending when serving, like possibly a spondy or something.
Good, good. So then then that's where, again, understanding a spondy is like a stress fracture, stress reaction. So why wouldn't the x-rays or MRI find it? And that's understanding that idea too, where x-rays are not great. MRIs are only good too as the person, what they're looking for. So if they're looking for disc herniation, which this doesn't sound like, then they might miss some of the subtle things that we would want to find. So I just had a case just like this, and you just worry that they might miss, you know, that part. And the type of person that's looking at it is not necessarily looking for what you want them to. So yeah, and then obviously any type of strain of muscles can throw you off, and then that's where, again, where you can kind of say, let's start with these basic treatments and then move on. I think always keep it in the back of your mind when it starts talking about back pain, that's when we get into some of those more insidious issues with spinal cord tumors, things like growth inside the spinal cord, tether cord. Then obviously osteoma is one of that on the test they'll often give you, where they'll that's kind of the most common one to have just nighttime pain and just kind of random back pain. Obviously you would expect the x-ray and MRI would show up on that. And then just remember, back pain in children less than 18 is almost always pathologic until proven otherwise. So this is not where you want to just assume that they strained something. You really want to be diligent. Again, understanding what spondylolysis is, where you get that bone defect in the pars interarticularis. Obviously, gymnasts have a high rate of it. Anyone that's arching their back all the time is going to have a high likelihood. This is where a clinical presentation, trying to kind of know where tightness, hamstring tightness is very common. And then you got this positive single leg Stork test where you're trying to isolate their back, arching back. So you have them stand on one leg and arch back, and that's going to put stress on just one side. So that's kind of the most likely thing, that if that's positive, you got to really keep this high on your differential. And then x-rays, making sure we do the obliques. Does anyone remember what sign you're looking for on the obliques?
Scotty dog.
Scotty dog sign. Yeah. So like looking for the collar on the Scotty dog. And that's where if you got x-rays and you didn't include obliques, you can't see the Scotty dog. It doesn't stand out. And so making sure we do that. Bone scans, again, starting with these just to rule out the major problem and then kind of keeping it in the back of our mind. I mean, anytime we start seeing the slippage, that's when it gets into the spondylolisthesis, and the listhesis is that slippage. And so often on the test, they'll tell you about the whole thing is slipped forward. And that's, again, a separate entity where you get bilateral and some slippage forward. And then these sometimes have to be in braces, understanding that there's a variety of treatments. And then obviously you get into the back specialist dealing with the different ones on this. So this next case is a 14-year-old ballet dancer who was stretching and felt a pop in her buttocks and she couldn't finish class. Now she's limping and complaining. She's tender over her right ischial tuberosity. Does anyone remember what this is?
The avulsion fracture.
Good. So again, understanding the avulsion component of things, this is where that pop and everything, you'd say, well, did they tear some tendon? But the avulsion fracture would be, again, most likely, as we talked about previously, and we got all these different locations. I think we went through that last time. This one is a 14-year-old pitcher. He's recently receiving some hamstring strain. So again, that history is just one of those things you keep in the back of your mind, which just says, okay, was he growing and has that tightness? He is the best player on his team, so he plays a lot. He plays on multiple teams, which is never a good thing sometimes. And now he's complaining about arm pain. So again, a very non-specific thing, but unfortunately, sometimes they don't come in saying it hurts one place. They kind of, you say, point to where it hurts, and they kind of grab their shoulder and then go like this. And it's like, that didn't help me. And then obviously your physical, like Stallworth always says, will be pointing it to certain things. But I think this is where in your differential, you just got to come up with some very common things that you got to rule out early on. So what sort of things are you thinking about in a person that's throwing a lot with arm pain?
I mean, it can be shoulder or elbow.
Yep. So what do you think of? And when you say shoulder or elbow, what are some of the problems you can have?
I mean, you can always end up with some sort of like tendonitis in the elbow from either direction.
Yeah. So there's there's tennis elbow and golfer's elbow, which pitchers can get. So, and golfers can get tennis elbow, and tennis players can get golfer's elbow, because it just has to do with like the location and the most likely thing. Again, those are tendonitis issues, and so certainly ruling those out are important. But again, when he's younger, then it opens up a possibility for different injuries. So what else can you think of?
Rotator cuff.
Rotator cuff, good. So again, if this was a professional athlete, rotator cuff would be high on the list. In arm pain, if it was shoulder specific, rotator cuff would certainly be up there and testing their strength. But this is where, again, when you test their strength, it could be painful to move because of something else, and it throws you off. So they're not weak from tendon muscle problems, but weak from pain. And so this is where understanding that another diagnosis in the shoulder would be possible. Can anyone think of another possibility of shoulder pain in this little leaguer?
You realize we can see your next slide.
Oh, you can?
Yeah.
Oh, that makes it easier. You still didn't say it.
Little leaguer shoulder.
Yeah. So we got little leaguer shoulder. So this is where, again, understanding that this is a possibility. So the fact that the little leaguer shoulder is an apophysitis or osteochondritis, understanding that this is on the differential and high up there, you're going to have to look at this a little bit different because, like I said, your physical exam isn't going to necessarily help you because it might hurt with all the movements. And so understanding how we're going to approach that, this is where you would say, okay, I got to get an x-ray to look and make sure it's not this, versus in an older person, you might not really care as much about the x-ray. Understanding how you would do this also is knowing that you're trying to look for the widening of the humeral physis. So therefore, you're probably going to want to get contralateral side. So when you see it, you're not like, is that a little wide? You know exactly that it's wide compared to the non-throwing arm. So this one is pretty obvious without the comparison, but this is comparing the same kid on the other side. Sometimes you can get in the different angles that help you. Obviously, that's where multiple views comes into play. And again, the test question on this one will be how to treat it. And this is where making sure that they understand that throwing is really the main thing. And so you have to shut them down. And, you know, most of the time we're saying months at a time. And that's a hard thing for someone that's been playing baseball for years straight almost, right? So, but this is where that diagnosis, making sure that they understand. And obviously you might refer them to an orthopedist, but that's where you can sometimes be detrimental because you're giving them hope by saying, oh, go see this person, when you know that this is the problem. You tell them that, and you can have them decide when they go back, but making sure that they fully understand, just like with concussions, you should not be doing that right now because it will not heal without that. And then one thing that I see sometimes when you come into play is, again, where I've seen a baseball player that comes in because they lift up their backpack and then all of a sudden had pain. This is where understanding acute on chronic injury. So this is where it's very important to ask them, okay, did you have pain before that happened, even minor amounts? Because like I said, I had a patient like this, and then everyone was thinking, well, he tore something happened, when really he just had little leaguer's elbow, which is, again, an apophysis of the medial epicondyle, and he'd been pitching too much. He'd been having pain for a long time, and then he just had that instigation that threw him over the top. Same thing I've seen with Osgood Slaughters, where they were playing basketball and felt immediate pain, and you think it's an acute injury when really it's a chronic. So this is where your history comes in and is extremely important. And again, little leaguer's elbow is another one they'd love to ask about because it is a classic thing where you're getting pulling. And there's again, the contralateral side, and it gets into Panner's disease is that example of avascular necrosis that happens, similar to like leg calf Perthes disease, but this is in the elbow because of repetitive stuff. So understanding that that's a possibility. And again, when you see pain in different locations which don't match up perfectly, making sure you're attuned to looking at the x-rays in those spots, looking at OCD lesions also is possible. So if they get a lot of clicking, popping, catching, again, those mechanical symptoms, you're always going to be more worrisome and investigate more. So elbow pain, again, this is where instead of tearing like their UCL ligament, they're going to pull off that that medial epicondyle. So the x-rays might not show anything major when you have tenderness and pain. And that's where sometimes if it's not significant, you can just have them rest for a couple weeks and then reassess. And again, that's where certainly reason we'll have them see someone more. But again, they're resting in the first 2 weeks because, again, if you don't tell them that, they're going to keep doing that. And these often chronic overuse injuries it's very important to hear from multiple people that you shouldn't be stressing that area. And the only way to get them better is to rest it. And then obviously physical therapy sometimes to get back and a graduated increase back to throwing. So there's like these little league throwers programs where you're throwing little bits more and more. So this one's a 15-year-old that plays soccer and basketball, has had pain for 1 to 2 months, doesn't recall anything, except he did accidentally run into a sliding glass door 2 weeks ago. His pain is worse with weight bearing, leg extension. He says that it feels like something is catching when he's walking. So what sort of things are you guys thinking here?
Sounds like a meniscus.
Right. So meniscus is always high up there. if I had to say, if I told you he had an MRI that said it wasn't his meniscus, what would then be right after that?
I mean, that seems kind of minor for an ACL.
Yep, good. So I mean, obviously you're worried about those sort of things too. There's actually a very common like thing that masquerades as meniscus tears. Does anyone remember what plica is? So plica is the folding of the synovial joint line. So sometimes people get a thickening of the plica. So instead of the meniscus being torn, it's actually the plica inflamed. And so they'll feel these catching, popping, clicking. And so that's one that I see often. People are like, oh, that's a meniscus. And then that's where I'd say, no, it's not. And what would be the big thing with a meniscus tear? Where is the pain located?
Really? Along the joint line? That's it?
Joint line, good. So, and that's where, because that's where the meniscus is, right? And so all of a sudden, if their tenderness mostly superior over that, like over the medial epicondyle of the femur, well, that's not the meniscus. That's not where the meniscus is. That's where the plica is. So understanding that they can have the history very much like it, but then your physical exam is going to help you. And this is where having a good physical exam findings and confidence in your physical findings can help you a lot. Understanding what the McMurray's test is, where you're bending, stressing those areas. Again, like you said, ruling out the ACL, because if you have an ACL tear, then you would be more likely to have a meniscus tear. So if that's torn, then it doesn't really matter where else you're tender. It's like, we're definitely going down one path. And then don't forget about neurovascularly evaluating all these injuries too, because that's where, again, we don't want to be missing where nerves or dislocations or certain injuries can cause neurovascular problems, which are again more emergent, and you can be very much in trouble for missing. So again, remember where the joint line tenderness would be. I think that's where, when you're examining someone, understanding why you're doing that, feeling the different ones too, and certainly sometimes the physical exam isn't perfect. And so that's where, again, when you get down that road and you say, okay, there's joint line tenderness, limited extension of the knee, what are you guys thinking in that case as far as what would you be worried about? And again, this is where pain sometimes is obviously the limiting factor, but if you start having mechanical symptoms, can you guys think of instances where it's not just a meniscus tear, or again, the meniscus tear isn't something just like, okay, deal with that at some point, but you have more problematic areas. So this is, again, things you don't want to miss. So one would be like a loose body. So that's where the OCD lesion comes into play. So those areas where you get a little bit of cartilage pop off, and that kind of gets stuck in the joint. Can anyone think of another? It's kind of a classic thing that like a little kid, like a 9-10-year-old, it would be on the test, jumping on a trampoline, his knee buckles, he can't straighten his knee now. So what does he have?
Some sort of problem with the patellar tendon or the extensor, something there.
So that's possible, yeah, like some type of tear. But say he has joint line tenderness, and then say someone, and then say the mom said, I think it's his, and again, this is where understanding the breadth of it, and this is a very specific problem. So these are all OCD lesions. This is an MRI finding where you'd see a meniscus tear where you basically have the absent bow tie sign, so you don't have that other meniscus that kind of just ripped apart. But in the kid that we specifically said, this is actually what's happening. So the radiological finding is a double PCL sign, but what is actually happening here is you have a meniscus tear that is pretty significant, and then you get the buckle handle tear. So it's actually flipping up. So a whole piece of the meniscus flips up and then then like locked in the joint. And so it looks like this, right? So like a whole piece flips up. So this is where, again, on the test, they'll often give you this buckle handle tear, which is mechanically keeps them from being able to extend. And this again is a more urgent thing because while that thing is being pinched off, stuck in that position, it can start to die. And so these are where, it's not just order an MRI, send them to the, but like calling the orthopedic surgeon to say, hey, this person's not moving their knee appropriately. I'm worried about this. And that's where the test question usually goes. Does that make sense? So that, like I said, the buckle handle meniscus tear is one of those very common ones that people want to not have you miss. So they put that on the test because if you miss that and then they go and see the orthopedic surgeon at some other point, they're often removing their meniscus versus repairing their meniscus because it's died over time. Similar to the neurovascular problems, compartment syndrome obviously is one of those things you don't want to miss. Nerve entrapment, things that by delaying the care can cause some much more deficits, and so we don't want to do that. So again, prevention wise, just to go over a couple things in that area. And I use this quote by Cal Ripken because he actually was an example of a baseball player that didn't play baseball until he was in high school. And so often when kids are pushing themselves to the limit and pitching all the time and doing all this stuff, they know Cal Ripken for his record for most consecutive games played. And so he always jokes that, or he says records are meant to be broken, not athletes. And he's an example of where not playing too early, not doing it too much, let him then break the record in the professional ranks. I think understanding that these injuries have more ramifications too. So obviously brain injury is one that we could get a lot into, and obviously we talk about that separately. But even one study looked at injuries and surgeries after these sports injuries. 1/3 of these patients failed a test for the first time after an ACL repair. And you'd say, well, what does that have anything to do with it? But there's a lot of being behind, being stressed about trying to catch up. And so these injuries have multiple layers that I don't think orthopedic surgeons are always thinking about. So I think it's very important for you all to always consider this. So when you do have a patient coming in for other injuries, that you're at least acknowledging this and trying to figure out if there's something you can do to help them in these situations. And obviously there's a huge psychological component. So there's this website After the Injury, because this is where a kid's whole life and identity is sometimes wrapped up into their sport, and then they're kept out of it. So there's a lot of indications for depression, anxiety that comes along with this, and can downstream cause a lot of issues that, of course, the bone might heal and the injury might heal, but then these things become a very problematic thing for the rest of their lives. So obviously, like we talked about, helmets can help a lot. They reduce injury by 85%. It could prevent over 100 deaths a year if people always wear their helmets. The amount spent for bicycle helmets save $30 in direct care. So it's one of those that if, why we have things like Safe Kids that buy helmets for everyone, because it actually helps the burden on the system. Prophylactic braces have always been something people ask about, but those sometimes increase lower extremity injuries. So again, this isn't where just the more protection, the better. Baseball is one of those that has a lot of equipment. You might see in the playoffs right now, you might see a batter walk up to the plate with like basically protection of his face, his elbow, his knee, his leg, and he's fully protected. And again, those sometimes can be very helpful. But then there's things like this heart monitor, heart guard that is supposed to help with commotio cordis. And so I know a lot of people that buy them, but unfortunately the statistics say that it doesn't have anything to do with helping. Using softer balls is actually better than that. And so that's where, again, sometimes people fully understanding these things. Breakaway bases have been very helpful in the lower leagues. Again, so sometimes even if you're not directly involved in the care of this, if you are a pediatrician and have kids and your kid is playing rec baseball, talking to them about ways to prevent these injuries, and obviously maybe even having to do some fundraising to get the breakaway bases, which my son's league does not have. Understanding the mindset that goes into some of this, because again, coaches pressure kids to play often. So you often ask kids like, well, why did you keep playing? And you think it's all on the kid, when a lot of times it's, you know, they're just trying to listen to what, unfortunately, that, you know, their coaches are saying, or even their parents. So the AAP recommends that kids be 6 years old before they start playing team sports. Again, that's a kind of a weird thing. And my daughter just started playing at 5 t-ball. And I can see where this comes in, because again, where if I'm not there all the time, does the coach keep telling her to, you know, run and keep trying to be like everyone, all the boys, when she's not even, she's tiny and she can't, you know, stay up with them. They don't really appreciate that fact. So there's a lot of things, and obviously I'm not putting her in to start early, but she likes to socialize in the dugout more than anything. So it's mostly for that component of things. Educating people on when that, again, it's very hard to make it to the pros, but understanding that this is about trying to have fun, which is what the athlete's #1 reason for playing is. And winning, actually 90% would rather be on a losing team and play than be on a winning team. So it's kind of funny to hear that from kids. So obviously you know, there can be a lot of pressures and a lot of things that are adding to this issue. And so making sure that we fully educate everyone on this idea is very important. And again, like we said, understanding the different pain types, understanding that need to treat these early on to prevent the problem. 3 months off, 10% rule of increasing over time. So we're not pushing the body too hard as the body is trying to adjust in these adolescent kids. Proper hydration and those sort of things can be extremely important on the proper growth and maintaining the proper structures. It's very important. And then again, that's where if someone's having a little bit of pain, at least throwing out there that it could be a stress fracture, so they understand that. Because a lot of times I get kids coming in saying, well, there's no way I thought it was broken because I could walk on it. And that's obviously not true. So everyone's pain tolerance is a little bit different. There's a lot of educational resources to help with these if you ever want to know more or provide more information to people. And there's a lot of groups involved in this. And I always, at the end, always have to say, because it just sounded like no kid should ever play sports, because we talked about all the injuries and problems. So there's obviously a lot of benefits to playing sports, including the physical fitness, developing the proper motor skills, again, that understanding how to stay out of trouble to be able to play. So I think there are some kids that, some professional players that said that if they didn't have these, they would end up in my other job at DJJ and in jail because of just being in the wrong place at the wrong time. And so it's something that can be extremely beneficial to people. So just a little summary. Any questions or thoughts or examples that you've seen? And like I was saying earlier, these lectures, obviously, I don't feel like you're ever gonna come out of them like, oh, okay, I'm gonna treat all these fractures, I'm gonna treat all these injuries. A lot of the idea is understanding the breadth of that they're available, and then things not to miss, and then again being able to encourage people in the proper beginning, the proper treatment path. And like I said, you'd be surprised sometimes how often these little things get missed, because again, if it's not broken, it's fine, type thing. So any other thoughts?
was a great lecture. Thank you, Dr. Holloway.
Good, thank you. Just let me know too if in the future or you ever come across, because like I said, I think this is where sometimes the direct patient and kind of understanding when you see it, because it's hard to go through, and then hopefully on the test you'll be able to recognize some of the commonplace ones. So y'all take care.